enzyme, both of this noradrenaline and adrenaline, with the help of the monoamine oxidase especially in case of the neurons bodies, they are going to act, and ultimately with the help of the catechol O methyl transferase, it is converted to MOPEC and DOMA. Then both of these things are, especially the adrenaline and noradrenaline, they are converted to metanephrine and normetanephrine respectively. And once again, the metanephrine is acted by MAO, monoamine oxidase, to form 3-methoxy, 3-methoxy, 4-hydroxy mandelic acid, or it's also known as vinyl mandelic acid. And ultimately, this is going to be excreted in the body. And it's already yesterday we have learned that the MAO and catechol methyl transferase, both of these do have the significant action in metabolism. However, when compared to the very fast and stringent action of the acetylcholinesterase, it is not so powerful system. Whereas the reuptake system is one of the important system which terminates the action of norepinephrine. Whereas acetylcholinesterase is the only enzyme that is going to destroy the secreted acetylcholine with a flash type of the reaction. And once again, here there are varieties of the drugs which can inhibit this step. This is the pharmacology of this particular neurohumoral transmission, and the tyrosine is uptaken with the synaptic what you call as the cleft, then it is converted to dopa, and dopa is converted to dopa, whereas this step dopa to dopamine is inhibited by alpha methyl dopa, and reserpine is going to inhibit the uptake 1, especially uptake. And this vesicular uptake of the norepinephrine in the storage vesicles, and hence it is made as a substrate to monoamine oxidase enzymes. Whereas the reserpine is also going to deplete the norepinephrine, as it is going to inhibit the what you call as the inward movement of the norepinephrine inside the vesicle. Whereas the guanethidine is going to displace norepinephrine from the uptaking sites. Whereas the ephedrine, amphetamine and tyramine, they are going to what you call as have an exchange mechanism between the norepinephrine outside, whereas the monoamine oxidase is an enzyme. It is going to what you call as convert the norepinephrine to a vinyl mandelic acid, or the COMT is going to convert the metanephrine to normetanephrine. And ultimately, in the synaptic cleft, the COMT is present in synaptic cleft, whereas the monoamine oxidase is present in the axonal terminal. So these are all the what you call as some of the important what you call as these important things, especially the drugs, which can interfere with the pharmacological, this physiological action of some of the impulses, and this is can be called as the pharmacological action. And here also alpha and beta type of the postsynaptic receptors are there, whereas the alpha 2 has the presynaptic receptor, whereas the alpha is a postsynaptic receptor in most of the cells, except there is a exception for everything. Some of the types, this alpha 2 is postsynaptic and alpha 1 is presynaptic in nature also. And the interference with synthesis release of the transmitter. So what happens is the cholinergic nervous system, hemicholinium, or which is also known as HC3. See, please remember this very important what you call as name of the drug. HC3 is a synthetic compound which blocks the transport system by which choline accumulates in the terminals of cholinergic fibers, thus limiting the synthesis of the acetylcholine store available for the release. So, hemicholinium is the one which blocks the transport of choline inside the presynaptic cell or uptaking of the choline. Hence, it is going to terminate the action of acetylcholine. And each step involved in neurotransmission represents a potential point of the therapeutic intervention. See, as the steps becoming complicated, we do have many steps to inhibit that particular thing or exaggerate that particular thing and get whatever the pharmacological response we need. And another thing is the vesicule blocks the transport of acetylcholine into its storage or preventing the release. See, the vesicule blocks the transport of acetylcholine into storage sites, whereas the hemicholinium it's going to inhibit the uptaking of the choline from the peripheral nervous tissue, or the whereas the vesicle blocks transport of ACH into storage sites, preventing its release. The site on presynaptic nerve terminal block of the acetylcholine released by botulinum toxin. So Clostridium, we know that it is going to secrete varieties of this toxin, especially Clostridium botulinum. It's going to release the botulinum toxin, and the botulinum toxin is going to block the acetylcholine release by the membrane, presynaptic nerve terminal, and death usually occurs, especially in case of the respiratory paralysis. So the botulinum toxin is present in any decaying material or any material which is affected by Clostridium botulinum, and the preformed botulinum toxin is ingested by the animal, and the toxin is going to act on the terminal block and it inhibits the release of the acetylcholine, and there will be flaccid paralysis. So when we inject locally the botulinum toxin, and this is used in the treatment of muscle dystoniasis, means whenever there is a functional disorders of the skeletal muscles, and another disease known as the palsy, and certain ophthalmologic conditions. So the botulinum toxin, it is surprising, but it's true that just like podopilotoxin, botulinum toxin is used as a therapeutic agent in very small doses under the above condition, especially muscle dystoniasis. Coming to the adrenergic system, already we have learnt about the cholinergic system, how it can be interfered and how the different steps can be inhibited, etc. Then adrenergic system, alpha methyl tyrosine, or it's also known as metyrosine blocks the synthesis of norepinephrine by inhibiting tyrosine hydroxylase, the enzyme that catalyzes the rate limiting step, especially conversion of tyrosine to dopa. This is alpha methyl tyrosine. It is going to block the synthesis of norepinephrine, and ultimately we can see that the action of adrenaline on the different tissues will be inhibited. It's a rate limiting step. Methyl dopa, an inhibitor of aromatic L-amino acid decarboxylase, is like dopa itself because it is having the structure activity relationship that of the dopa. So it successively, alpha methyl dopa, successively decarboxylated and hydroxylated in its side chain to form putative false neurotransmitter, that is alpha methyl norepinephrine. What's a false transmitter? It is very similar to that of the dopa, but it acts in a different fashions, that it is going to mimic the action of the dopa itself. That's why it is called as the false neurotransmitter concept. That means the L-amino acid decarboxylase action is going to dopa, whereas the hydroxylated, what you call as the L-dopa, L-amino acid decarboxylase dopa, it's a fast neurotransmitter and it is converted to alpha methyl norepinephrine. And beryllium and quinidine are the true drugs. They act by preventing the release of norepinephrine by the nerve impulses. So they are going to inhibit action. Whereas the quinidine can also potentially deplete the tissue stores of catecholamines by inhibition of the vesicular transport system for such amines, quinidine and beryllium. Both of these drugs are transiently stimulate the release of norepinephrine because they are going to displace the amine from storage site, especially in the storage vesicles, quinidine and beryllium. They are selectively taken up by the cells of, especially the nervous cells in the storage tissue is depleted and displace the amines. And many pharmacological activity may also be expected from these drugs. And promotion of the release of the transmitter. Here, different steps, especially the neurohumoral transmission, can be pharmacologically intervened, and cholinergically, in the nerve cholinergic, the ability of the cholinergic agents to promote the release of acetylcholine is limited, presumably because acetylcholine and other cholinomimetic agents are quaternary ammonium compounds and do not readily cross the axonal membrane into the nerve ending. So, the black widow spider is known to cause a transient release of the acetylcholine. So, the adrenergic nerves, several drugs that promote the release of adrenergic mediators, especially so many drugs are there, where they are going to increase the release of adrenergic neurotransmitters. And here you can see certain drugs like tyramine, ephedrine and amphetamine. So these drugs cause a rapid liberation of transmitter and produce sympathomimetic effect. So these are all called as doping agents. Ephedrine, amphetamine and tyramine. Ephedrine is a bronchodilator. So what these drugs are going to cause is they are going to liberate or they are going to increase the exocytosis process of the neurotransmitter and produce a marked sympathomimetic effect. Whereas the Reserpine is going to block the vesicular uptake of the amines and produce a slow and prolonged depletion of the adrenergic transmitter from the adrenergic storage vesicles, where it is largely metabolized by intraneuronal MAO. What happens? So, this Reserpine is going to block the uptake too of the amines, especially norepinephrine, epinephrine, dopamine, etc. So, if it's that means if the storage vesicles cannot be stored with that of the neurotransmitter, they will be acted by monoamine oxidase, which is present in the presynaptic exoplasm, or then they will be acted and broken down. That's why they become substrates for the monoamine oxidase, and ultimately the action is terminated. The release, the resultant depletion of the neurotransmitter produces the equivalent of the adrenergic blockade. And apart from this one, Reserpine also causes the depletion of serotonin, dopamine, the other two amines, and action is due to the depletion of transmitter other than the norepinephrine. So, especially in the central nervous system, serotonin and dopamine are the two important what you call as neurotransmitters, and whenever you administer Reserpine, then you can see that the serotonin and dopamine are destroyed, especially in the central nervous system, and you can expect the respective actions. There is what you call as congenital dopamine-b-hydroxylase deficiency. Congenitally, dopamine-beta-hydroxyl (DBH) cause a syndrome. It is characterized by the absence of norepinephrine and epinephrine, because if you inhibit the enzyme dopamine-beta-hydroxylase, this hydroxylase, usually dopamine and subsequently norepinephrine, they are not formed. Norepinephrine to epinephrine, they are not formed. And elevated concentration of the dopamine is seen in text baroreflex afferent fibers and cholinergic innervation, and undetectable concentration of the plasma dopamine beta hydroxylase activity is seen. This is an evidence that this enzyme can also be inhibited. So, this is going to cause the postural hypotension accompanied by other symptoms. So, whenever there is a deficiency, congenital deficiency of the dopamine-b-hydroxylase, which is a what you call as one of the important enzyme which converts this norepinephrine to epinephrine, etc. So there is postural hypotension. Depending upon the posture, there is hypotension. And dihydroxyphenylserine. Dihydroxyphenylserine is one of the drug that is going to cause the improve in the postural hypertension. Because why we are learning all these things is there are certain conditions which are depending upon the adrenergic transmission, and we can interfere. Dihydroxyphenylserine is a drug that is very effective in case of the postural hypertension, and the therapeutic approach takes advantage of non-specificity of aromatic L-amino acid decarboxylase, which synthesizes the norepinephrine directly from this drug in the absence of dopamine beta hydroxylase.